what I'll do is I'll tell you a little bit about how Orca got started and why it got started, and then what we do and how we do what we do, and then just ask me any questions. So, and I can share slides if that's useful, but I'll just talk, and then if you want me to share any visuals, I can do that. So, Orca, actually, so I'm the chief exec, but I'm also the original founder for Orca. And what happened for me being clinical was that, way before we had technology, seeing patients face to face. And I was so excited about doing that job. And the first day I started seeing patients in clinic, I thought, this is really exciting. I'm going to actually start to achieve what I want to do, which is to help people. And at the end of the first day, I felt really frustrated because I'd only seen 6 patients. And I thought, well, what about everybody else? How can we actually provide healthcare to all the people who need it, given the fact that I can only see 1 patient at a time? Sounds so basic, but that was my underpinning frustration. Now, at the time, this was way before we had smartphones or even computers on our desk. So I got interested in stripping out waste in a process and redesigning care pathways so that we could then, as clinicians, see more patients. And, we managed to transform the way in which I delivered care. I started seeing 10 patients a day, got the whole service to start seeing 10 patients a day, went round lots of different services doing the same. And we radically improved waiting times from 18 months to 11 weeks within a 3-month period. So it was quite radical.
Wow. What setting was that, Liz?
I did that in community care, primary care and acute care. And I also did some of that across social care as well. So in England, that's with local authorities. And then I also then started to work across the system. So not just looking in chunks of the system, but also looking at the flow from primary care into acute, back into the community and into social care and even care homes. So started to think about whole systems. And it was around about that time, which was probably about let me just get this right, about 2010, we started to structure the healthcare system here in the UK to be more integrated, to think about an individual user journey across the system. And it was around about that time that we started to see technology emerge. So we had electronic health records. We now had computers on our desk. We now had emails. People started to buy these phones, mobile devices. And then you fast forward another couple of years, start to see the rise of digital health technology. And I got really excited because I thought, not dissimilar to what you said about health apps. At the time, there was about 30,000 health apps. And then my job across the NHS actually was to drive uptake of digital health technologies so that we could see improvements in patient health outcomes, but to also support the economy to thrive so that these companies could grow and have more people working for them. And I thought, this is great. And I thought, this is the answer. This is it, because millions of people can have access to technology all at the same time. And everybody's bought these devices, which means that they can have it whenever they want it. But there's massive barriers to adoption, and it was really hard work. And the reason it was hard work was because nobody even knew that these technologies existed. They weren't even aware of where they would go to find these technologies. They didn't know whether they could trust them, and there was no system to establish safe recommendation and governance of these technologies. And I started thinking, well, how do we do this in the world of drugs? So in the world of drugs, we have a very clear testing process. So the drug is tested for safety. We then have an evidence test. So here in the UK, it's NICE, National Institute of Clinical Excellence. That drug then enters a formulary. We're trained in these drugs. And then there's a prescription infrastructure that allows for the safe prescription and ongoing governance. So we know what drugs have gone where. There's a reimbursement that's connected. And so the whole infrastructure is established. And at the time, there wasn't anything like that for digital health. And we have about 20,000 drugs. Well, now in the world of digital health apps, we've got about 360,000.
Yeah.
And without that infrastructure, we're asking doctors and healthcare professionals to prescribe or recommend these technologies without any of that infrastructure. And so what happened was, before I founded Orca, I actually then took jobs across Europe and North America, and I thought it would be easier in other countries, and it's not. It was exactly the same. And so, set about founding Orca, and the mission actually is to improve lives through digital health. But the way in which you do that is to break down the barriers in a very systematic and scalable way. So what Orca do is we review and assess technologies. And we're assessing technologies not just for clinical safety and clinical evidence, but also around data privacy, data security, user experience. And the review bit is different to a drug because you have to do it repeatedly.
Exactly. That was also one of the things I would like to ask you, because setting the frame or the review process as you review pharma products is a great way, but there are many really fundamental differences. For example, using algorithms that update 30 times a year or even so. How do you deal with that in Orca?
We review it. So what we do is we review proactively every time the technology updates, and the way in which we do that. So we spent a lot of time building a review engine. So it's a manual review process which hands off to clinical experts and subject matter experts, but it's coordinated through a system that we've built, and that system checks for updates on a weekly basis for the technology that's been reviewed. And it flags a re-review if a product updates. Now, a re-review may be they've updated the brand. That's fine. If it's incorporated AI and a clinical decision-making function, we now need to really properly re-review this technology. But we only reassess the bit that's changed. So a re-review is very rapid. The compliance data is held in a vault, in a database. And so we're able to keep on top of the quality compliance. So we've reviewed 17,000, or maybe 18,000 technologies now, and we add around about 200 to 300 new technologies a month.
Wow.
To that repository.
So you say technology, so it's not only apps at the moment. Are you also including wearables and so on?
Yeah, it's the software associated with the wearable. Okay. There's already a very good process for the actual hardware technology. But say, for example, Fitbit, that's a wearable. We're assessing the software element of that technology.
Right.
So, but we also do web-based solutions, native apps, etc. So we do that continuously, but that's only the first step on the journey. The other bit, just to mention on the review, is we're able to review globally. So we can add different questions into the review process, depending on where we're working. So if we're working in the Netherlands, or we're working in New Zealand, or we're working in the Middle East, there's a lot of questions that are the same, but there are some differences. So we just layer the differences in, and we're also able to share the compliance data. So that is really the core foundation of what we do. But then what we have are digital health libraries. So this is the equivalent of having on general sale drugs. So people can now search for safe technologies to help them either stay healthy and well or manage a condition.